So, if you guys don't know me, I'm Mallory. I'm in the critical care service. Will you turn that down a little bit? Thank you. And we're going to talk about the CPR RECOVER Guidelines. These initially came out in 2012, but they've been updated just this past year in June. So it's for the most part, if you guys are familiar with the RECOVER Guidelines from previous, they're very similar, but there are a couple of big differences that are important, especially moving forward with codes in our hospital. So just so you guys know what RECOVER actually means, it stands for the Reassessment Campaign on Veterinary Resuscitation. And prior to having the RECOVER guidelines, there was no protocol for veterinary CPR at all. It was all information from coworkers, the doctors that you worked with, what they had learned in vet school, what they had done in practice. There was no standard protocol like there is in human medicine. So now, like I said, since 2012, we have the RECOVER Initiative, which is ultimately our veterinary CPR protocol. I think I have to click to go. There we go. So preparedness and training is super important, which is why we're here today. Obviously, refreshers are really important for those of you that don't participate in CPR very often or don't have a whole lot of experience in ER, where we would most often be doing this. It's really important to have the refresher. If you don't use it, you lose it type of stuff. And hands-on practice is really important too. Unfortunately, we're all digital here today, not in person, but we do have the models here at OVRS if you guys ever want to give it a try, or oftentimes in ER, once we've done a code, or if we are sort of on autopilot for a code, it's very common for the doctors to ask people if they want to practice doing their chest compressions. So there's always opportunity to get your hands on practice if you need it. Just let us know. So code status is super important. We have it for every patient that stays here in the hospital with us. And as you guys know, in ER, we always have it posted on everybody's treatment sheet. And obviously we get all this information when they're admitted. I always try to tell people that it does not have to be your final answer, but this is the important information that lets us know where they would like us to start. Because if they are unsure what they would like to do as far as resuscitation, and they ultimately choose their patient to be a DNR once they're admitted, if we're trying to reach them by phone, it's going to take us a good couple of minutes. We're going to have to explain what's going on. There's going to be a whole lot of emotions going on. So we're losing minutes while we're trying to relay the information to the owner. If we know ahead of time that they know that they want CPR, we can just get cruising immediately while someone else tries to reach them by phone. We have them, as you guys know, posted on everybody's sheet. So if you're cage card, so if you're just walking by and you don't even know the patient, you don't know anything about it, and you happen to see something's wrong, you know exactly what that patient may need as far as a resuscitation status. These, as you guys are familiar with, are our emergency drug dosage sheets. They're really nice, super easy, because when you guys are trying to figure out drug dosages for patients, and A, you either don't have its weight handy, or B, you don't have the sheet handy, you have to refer to either figuring out the math quickly on your own, or using the chart upstairs where you have to like go across one row and then down one column to meet the correct volume that you're supposed to be giving, and it's not convenient in an emergency. So these are really nice as far as what doses you should be giving for each patient based on their weight. The crash cart, we have since updated ours, but as you guys know, it's in a central area where everybody has easy access to it. It's pre-stocked. Everything is ready to go for the next code, ideally, in every situation. All of the supplies that we need are there, that should be there. And after each code, we always go through to make sure that anything that we may have used is restocked for the next code. It's a little bit different now when we have those little red locks that go on the crash cart, but those serve the same purpose as this tape, just to let us know that someone has gone through the crash cart. They know that everything is there that should be. It's exactly where it should be in the cart, and it's functional and ready to go. So there's three actual aspects of CPR, and we'll talk about each of them. The most important, or the most common, I should say, most emergent that we see here is basic life support moving into advanced life support into the hospital setting. But we'll certainly talk about post-cardiac arrest care as well. The big take home about post-cardiac arrest care is that return of spontaneous circulation is never, ever, ever an endpoint. So we'll expand on that in a little bit. So basic life support, anybody can do this. This is just recognizing that there has been CPA or cardiopulmonary arrest. You're starting your chest compressions and you're starting ventilating for your patient. Recognizing arrest and taking action should be a pretty quick thing, like less than 5 seconds. Previously, as I'm sure in older CPR training sessions, especially for people, it was ABC as far as airway, breathing, and then circulation. But just as people have, they've sort of changed up the order to make circulation the most. So CAB, most important. We've also done the same in veterinary medicine. So your biggest priority, the thing you should always get going the fastest, your most initial priority always is going to be starting your chest compressions, so circulation. Once you've started chest compressions, then you can move on to making sure that the patient has a patent airway, that they are intubated, and start breathing for the patient. But the circulation, as in chest compressions, is always going to be your first step. As you guys know, the consequences of delaying basic life support delaying chest compressions or circulation are huge. So just for the same reason that I talked about knowing everybody's code status ahead of time, we want to make sure that we're minimizing delay in starting basic life support and make that time as little as absolutely possible. I know that there's been concern for some people, especially those that don't have maybe as much experience or are unfamiliar with CPR or haven't done it before or are just not comfortable. But I want you guys to know that less than 2% of patients that actually experience an arrest experience any serious harm when basic life support is started. So what that means is if you think your patient has arrested and you start chest compressions, but they actually have not arrested, less than 2% of these patients actually have any kind of negative, harm when you start basic life support. So please don't be afraid to do that. Or for patients that have arrested as well. Again, I'm going to drive this home a lot. Please move swiftly. Within about 4 minutes of the actual arrest, we've already experienced tissue damage because of lack of oxygen. So the longer that time goes on without as efficient of perfusion as we possibly can obtain for this patient, the more tissue damage we're gonna have. So our first letter of CAB, circulation, palpating the chest wall is by far my favorite and easiest way to tell if a patient has a heartbeat or a pulse. You can certainly use the femoral pulse for a lot of patients as well, but think about those that are, especially those in the ICU that have poor perfusion, their blood pressure is crummy anyways. They might not have an amazingly palpable pulse on their best day. So when they have experienced an arrest, you probably definitely are not going to be able to use that as a reliable pulse source. So for sure, I definitely would just palpate the chest wall. You can use your stethoscope if you have it handy. Please don't walk away to go find one. Give it a feel, see if you can feel a heartbeat. If you're ever in doubt, just start your chest compressions immediately. Breathing. So moving into our second letter, as far as circulation, airway, and breathing, the brief peek at the patient should also see if you are noticing that they are breathing. So super quick, again, are you seeing that the chest is rising and falling? Is there any movement from the chest at all? The big thing that I want to point out for this slide is that for those of you that are not familiar with agonal breathing, I want to show a little video, I'm really hoping it'll play. It's a little dramatic, bear with me, but I couldn't find a veterinary one. But I really, really, really need you guys to understand what agonal breathing is and that it is not normal breathing. You probably can't hear it. It's not a huge deal. It's more so once we get to a part in the video where it shows this dummy doing agonal breathing. So it's sort of like a gasping type thing, just like Joe here is doing right now. It might look like they're breathing. There is rise and fall of the chest, but it's not at all good breathing by any means. And it basically is telling you that either your patient has arrested or is literally about to. Usually these patients are sort of staring off into space, if at all. You know, if you're able to see their eyes, they're staring off into nothing. Nobody's home sort of thing. And it's sort of like a gasp, like a and sometimes you may not even hear the movement of air at all. It may just be the motion of their mouth in their neck and their head. And it's more so a reflex. It's not true breathing. So just make sure that you're aware and you are familiar with that, because it's not, we got to move into some sort of resuscitative efforts if you're seeing this in any of your patients. Compression technique is super important, and we'll talk about all the different techniques for the different sizes of patients and conformations of patients. Most importantly, though, we want you to lock your elbows so that you're not putting further stress on your body while you're doing chest compressions. So your arms, you know, straight out, as straight as you can make them, and lock your elbows so that you're not, your elbows are not bending at all. Our goal for chest compression rate is about 100 to 120 compressions per minute. I don't want you guys to focus on the rate itself. I don't want you to worry about your timing necessarily being perfect, but as we all probably do upstairs in ER that regularly do CPR, we probably all have some sort of song that we're singing in our head while we're doing chest compressions. Previously, it had always been Staying Alive by the Bee Gees that people would sing either out loud or in their heads while they're doing CPR. But I'm realizing that the more I present this presentation and as time goes on, people are more and more unaware of that song. So find your favorite that has the tempo. You can Google it. There's a bajillion songs with this tempo of 100 to 120 beats per minute. Justin Timberlake has some good ones. Beyonce's got some good ones. Whatever you can keep the tempo reliably in your head for your chest compressions. I will say that most people tend to compress faster than they should be. Just, I assume from the CPR experience themselves, trying to overcompensate to some extent. So just be mindful of how quickly you're doing your compressions. And another really important thing is to always make sure that you allow full recoil of the chest wall in between each compression. So you don't necessarily have to take your hands off of the patient or discontinue contact with the patient while you're doing chest compressions and in between each compression, but just make sure that you're removing all pressure from their chest wall so that it can expand as much as it possibly can before you deliver the next compression. A compression depth of about 1/3 to 1/2 of the chest width, so assuming they're laying on their side, is the ideal compression depth that we're aiming for. This is going to be dependent on the patient for sure. A lot of patients have much better chest compliance. Some have much less. So just a goal, does not have to be measured by any means, but we're doing a pretty deep compression. Really, really, really important. Even when you're doing the best technique in compressions, your elbows are locked, your rate is perfect, your depth is perfect, and everything could not be going better from a compression standpoint. We're only achieving about 25 to 30% of normal blood flow. So in order to even achieve that 25 to 30%, we have to be doing a really, really good job. We have to have good technique. So it's really, really important to make sure that we can maximize that blood flow as much as possible. Compression cycles. This is when a when the person that is doing chest compressions is doing their 2-minute cycle, this is ultimately when we're swapping. So from one compressor to the next compressor. So like I said, it should be performed in about 2-minute cycles. Keeping in mind, I mean, 2 minutes is the goal, but certainly keep in mind that chest compressions will make you tired, especially if it's a big dog or a massive dog or one with terrible chest compliance. You're going to get tired. And when that happens, you're oftentimes leaning into your patient and your compression quality decreases. So if you are tired to the point where you feel like it's affecting your chest compression quality, for sure, swap with someone sooner than 2 minutes. But the important thing about 2-minute compression cycles is that it takes about 30 seconds of consistent quality, good chest compressions to achieve what we would consider an acceptable cardiac output. So if we're constantly changing compressors because we're tired or for whatever reason, we're basically kind of taking that cardiac output that happens at that 30 seconds, and we're sort of resetting it every time we have a compressor. So it's really important to do your transition from one compressor to the next, and we'll talk about that a little bit more as well, as smoothly and as seamlessly as possible. Oftentimes the person that's currently doing the compressions and the person that's taking over for them are right next to each other. They're often, the new compressor is sort of getting into position while the current compressor is sort of scooting their way out of the way. And there's often a count off, like 1, 2, 3, and then a switch. And oftentimes, once you have some practice with this, it can happen almost completely seamlessly. Again, reducing the time or the pause in between compressors is super important. So communicate with your team, make sure that you know when they're coming on. Oftentimes in codes upstairs, people will remind each other, where they are as far as their 2-minute cycle for compressions. So talk to your team, make sure that they know where you are and where you're headed. There's 2 theories that help us maximize blood flow through the body. So the first is the cardiac pump theory, which basically means that we are physically compressing the heart chambers between the chest wall, sides of the chest wall during compressions, and we are literally squeezing the heart to send blood to the rest of the body. The thoracic pump theory is a little bit different in that we're not doing compressions directly over the heart. We're not physically compressing the heart itself, but we're creating a pressure change within the chest that ultimately causes forward blood flow through the heart and then to the rest of the body. So these patients, we're actually going to be doing compressions over the widest part of the chest to achieve the greatest cardiac output. And we'll certainly talk about which patients each of these apply to. So for really small patients, these are going to be probably those that are, less than 10 pounds on average. I want you to be able to make like a nice C with your hand so that your 4 fingers are able to compress really nicely up against your thumb. If you feel like your hand looks more like a parenthesis and you're not able to make a nice compression in between your fingers and your thumb, you probably need to bump up to the next compression technique. But for these little patients, you should be able to do compressions with one hand and directly over their heart. Again, with that nice C shape of your hand, compressing in between your fingers and your thumb. So in this one, because we're doing compressions directly over the heart, we're using the cardiac pump theory. We are physically squeezing the heart to send blood to the rest of the body. So an idea of some of these guys, these are going to be like your little foofer things that you can carry back with one hand. No ifs, ands, or buts. Puppies, kittens, really small things. You'll have to use your judgment when you get into like super duper small things, because even using one hand, you might have to be gentle with super duper small things. So just keep that part in mind. But we're not going to be using your standard, two-handed CPR position that we see oftentimes in ER. So Now we are moving into basically the next step up, the next size. So these are going to be small dogs and large cats. If you get to the point where you feel like your hand can't do a good compression in between those four fingers and your thumb, then we're going to have you move up to this one, this technique where you're actually using both hands. And we're going to put them directly over the heart. We're still using the same idea as we're physically compressing the heart to send blood to the rest of the body, but we're just using two hands so that we can get better compression technique. So again, these are going to be things that are a little bit bigger, still small, but bigger. You're definitely not going to be able to do quality compressions with one hand. You're definitely going to need two hands. And these patients, they don't have to be small necessarily by breed. They certainly can be larger by weight, definitely. Okay, so here we move into compression technique for medium and large dogs. So this is really, really, really important, and I really am gonna harp on this a little bit. I find that we don't take advantage of this compression technique nearly as much as we should. And the difference in this compression technique is that, sorry guys. Here we go. The difference in this compression technique is that we're not actually doing compressions directly over the heart. We're utilizing the thoracic pump theory here. So we're actually doing our compressions over the widest part of the chest, which is usually just before the last ribs or in that area. And why this is so important is because these dogs their chest compliance is not that we can physically compress the sides of their chest effectively enough to cause a good forward blood flow to the rest of the body. And instead, doing our compressions over the widest part of the chest will change the pressures within the chest and allow blood to move to the rest of the body in a far more effective way. So I have a lovely assistant. Her name is Mary Beth. She's going to come demonstrate for you. It's a little hard to see, but she's basically showing it's not directly over the heart. We're over the widest part of the chest. And obviously posture is super important. It's really important to be higher than your patient. So oftentimes we'll have these patients on treatment tables, often with a stool that we're making ourselves a little bit taller with to get better leverage over these patients and able to do better compressions without fatiguing nearly as much. Or certainly CPR on the floor, I guess, is also very possible. Certainly it might be harder to reach your patient, but from a compression standpoint, very acceptable. But yes, doing compressions when you are much higher than your patient is absolutely going to reduce your fatigue, especially in your back, but also your arms as well. So some ideas of these patients coming in, and I want you guys to remember that this is oftentimes like the standard size patient that comes into the hospital, like the most common, your medium-sized dogs to your large dogs. So please, please, please keep it in mind that these patients don't need their compressions right over their heart. It's going to be scooted back over the widest part of their chest. So a little bit of another caveat here, we're still into probably larger dogs. We're talking about keel-chested dogs now, those with a really, really, really skinny chest. And their chest is generally, 2 to 3 times taller than their chest width. And these patients, we're going to switch it back up, regardless of their size, switch it back up to doing compressions directly over the heart, because their heart, as you can see sort of in the picture, is so so ventral that we're actually able to well compress the heart between the two sides of the chest wall pretty well, doing compressions this way. So we're going back to the same technique as far as compressions right over the heart. heart. Our hand position is the same, our depth is the same, our rate is exactly the same. We're just moving back over to the heart. So these are going to be things like your greyhounds, often doodles I find are quite deep chested or keel chested, greyhounds for sure. The real deep chested skinny stuff, Dobermans. Okay, the last one, or one of the last ones I should say, is for our round patients, our barrel chested dogs. It doesn't have to be a large dog necessarily. The patient just needs to be round, you know, as wide as their chest, as wide as it is tall. And this is also another one that I feel like we don't utilize as much as we should up in ER. So please keep this position in mind for these patients as well. But with these patients, we're actually putting them on their backs, right? We're doing their compressions in dorsal recumbency like we would for people. So our chest compressions are going to be exactly the same, right? So our position is the same, our rate, our depth, all of that is the same. We're doing compressions directly over their heart, but we are doing it while they're on their back. And the reason for this is that these patients have much better chest compliance when you're doing compressions while they're lying on their back, as opposed to when they're lying laterally. You'll have more resistance when they're lying laterally than if you're doing compressions right over their sternum. So as I had mentioned before, there's a few changes to the 2024 adjustments to recover, and I've highlighted them all in orange. So this is one of the first things that have changed. Prior, it had been the same compression depth of about 1/3 to 1/2 for all patients across the board. But now, with the updated guidelines, they recommend only doing a compression depth of about 1/4 of the chest depth for these barrel-chested dogs. Again, does not have to be an exact science, but the take home is that we probably don't have to do compressions quite as deep for the barrel-chested dogs as we would for other patients. So again, these don't have to be patients that are large. These can be small patients for sure. Obviously, you'll have to adjust your pressure and your position, but these patients that are round do much better with compressions over their, on their back as far as cardiac output. Interposed abdominal compressions, we don't use it very often in the ER, and I think that's fine. I don't have a preference either way, but I want you guys to know that it exists and it's not quacky. It is a real thing. So what actually happens is someone's doing their chest compressions right over the chest as they normally would, and then another person is actually doing abdominal compressions. So right next door to each other, or right next to each other, and they're going in an opposite motion. So sort of like a seesaw motion. One is compressing the chest while the person at the abdomen is allowing recoil. And then the person at the abdomen is compressing while the person at the chest is allowing recoil. So again, a seesaw type motion over the abdomen and the chest. The idea behind this is that you're ultimately sending blood from the chest to the rest of the body. And then by doing the abdominal compression, you're helping send blood from the abdomen or the rest of the body back up to the heart. I think this is probably only a big helpful thing when you might have like a belly full of fluid, ascites or something along those lines that might be impeding your return to the heart. This might be a helpful trick in that sort of situation. But I would just want you guys to know that it does exist. It is a real thing. Ventilation is our next part of CPR, and I would venture to say one of the next important things, but not certainly not above your compressions. When you're intubating your patient, please do not ever ask somebody to stop compressing so that you can intubate the dog. Don't say, please, hey, hold on a second, I can't get this tube in. Just keep trying. Chest compressions are definitely going to be far more important. And the other thing to keep in mind too is that when you have the opportunity and you are intubating a patient in a non-emergent situation, try intubating them on their side or on their back or something different because when they're in this position and when someone's doing chest compressions, like the tissue is not in the same, it doesn't look the same by any means when they're on their side or on their back. So just get some familiarity with it, and a little bit more comfort in different positions can be really helpful. Make sure that you're inflating the cuff so that you can create a nice seal for ventilating for these patients. Positive pressure ventilation is ultimately how we're going to breathe for these patients. Ambu bag is our go-to up in ER, but you can always do it with an anesthesia machine, obviously with your anesthesia or your ISO off, but using your bag as your ambu bag. The tidal volume isn't super important when you're using an ambu bag, because the ambu bag will govern it for you. It will govern the pressure for you. And the pressure that the ambu bag creates is going to be a little bit more than it normally would be if we were breathing for like a normal healthy patient, because when you're breathing for these patients via ambu bag, you're also breathing against chest compressions often. So there does have to be a little bit of overcoming that pressure within the chest as well. But I don't want you to worry about overinflating the lungs unless you feel like they have terrible, terrible, terrible lung disease. But I mean, ultimately these patients are already dead, right? So we got to do what we got to do. These patients, ventilating for these patients, we're going to provide one positive pressure ventilation about every 6 seconds. So I do also find that we tend to ventilate quicker than we should for patients as well. So if you are the person that's ventilating, make sure that you're counting as you're breathing for these patients. If we're breathing faster, or we're breathing longer, or holding the breath for the patient, what we're actually doing is impairing venous return, because we're ultimately creating vasoconstriction, right? So it makes we're sort of working against ourselves to some extent. So a quick squeeze of the ambu bag, release, wait 6 seconds, squeeze, release. End tidal CO2 is one of my favorite things in CPR codes, because you can sort of gauge how well your compressions are going. The Emma is this little doodad that's attached to the end of this cat's endotracheal tube. And this is in the crash cart at all times. It's a nice little portable end tidal CO2 monitor. The fun thing about using end tidal CO2 with codes or CPR efforts is that if you're having an end tidal CO2 that's approaching or exceeding, 15 or 20 or so, is a very, very high correlation with increased perfusion, both to the heart and to the rest of the body, certainly to the lungs. And it is associated with an increased likelihood of return of spontaneous circulation. So in essence, the higher the number, the better your compressions are, generally speaking. So sometimes we can sort of use this as a guide if we go from one compressor to the next, and say, for example, we were previously getting an end tidal of 10 or something, and then we switch compressors and now our end tidal is 0 or 2. We're probably not doing quite as great of a job as far as perfusion goes now that we've switched compressors. So it can sort of give you a little indication that you might need to either compress deeper or make sure that your rate is appropriate, that sort of thing. So then we're going to move into advanced life support. And this is what ultimately happens here in the hospital. Obviously, owners can't intubate their patients at home or their pets at home, but they certainly can start chest compressions, and they certainly can do mouth to snout ventilations for their pets. But ultimately, advanced life support is going to happen here in the hospital. So we're talking about IV access, we're talking about drugs, transfusions, potentially defibrillation if the patient should require it. So an idea of what advanced life support looks like, there's lots of people. There's a lot of things happening all at once, and there's a lot of members of the team that each have their own job that they're working on as a collective effort. So the thing that I want to remind people, and I'll touch on this a little bit later as well, is that there is absolutely such a thing as too many people for a CPR code. We'll talk about roles a little bit coming up here shortly. But if there is a code and you don't have an immediate job to do, or you're not necessarily immediately needed, please step back. Because like I said, there's absolutely such a thing as too many people, people reaching over the patient, reaching, around, moving, that sort of thing. And we get in each other's way for sure, even with a normal size or an acceptable size team. So adding in more people just creates more chaos. Certainly stand by. I'm sure that we'll need something, right? But step back a little bit. IV access, as you guys know, super important. IV is the preferred method for drug delivery, but we can certainly do intraosseous for our little things, especially. It is more challenging. It is more time consuming. You do have to have some experience with it. For those of you that don't know, we do have an IO gun in critical care now, either for this type of situation, or we had a patient at one point that had terrible, terrible, terrible skin. And ultimately, intraosseous was the only way that we could safely and cleanly deliver drugs and medication, or drugs and fluids to this dog. But we do have it in critical care as a heads up. We can also do IV access in multiple places, right? So we tend to go for the cephalic veins most commonly, the saphenous, either medial or lateral, whatever you can access, accessories on the limbs, that sort of thing. Lingual, yes, it exists. It's not likely that you're going to use it, but it exists. It's there. But I want to remind you guys that the jugular is like one of my favorite things ever. And for a lot of people that will ask for help, like either poking a patient or placing a catheter or whatever, getting blood if we're having a lot of trouble, the jugular, please don't forget that it exists. It's going to be like your biggest vessel, your easiest vessel to find. I realize that obviously some patients don't have, we don't know if they are safe for jugular pokes necessarily, but also consider that your patient is dead, right? So we can sort of only go up from here type thing. Unless the doctor absolutely is like, do not poke this dog's neck for any reason type of situation, please don't forget that the jugular exists. Moving into drug therapies, there's 2 to 3 main ones that we use for categories of main ones that we use for each code. Vasopressors, these are going to be those that help us with blood pressure. So epinephrine is going to be our go-to most commonly. Vasopressin hangs out in the fridge over by surgery. This is sort of like I don't want to say a Hail Mary, but it kind of is. It's completely acceptable to use as part of your code, but it is a super expensive drug, which is why we don't reach for it immediately. And we kind of use it as one of our last efforts that we have for a patient, but it does exist. It absolutely is appropriate to use. You can use it in conjunction with epinephrine. It does not have to be in place of. Our anticholinergic is going to be atropine, right? So this is going to help us with heart rate. What I want you guys to remember is that atropine is kind of hanging out in the circulation once you give it, sort of just hanging out, waiting for return of spontaneous circulation, so then atropine can jump in and do its job. Atropine is not going to restart your dog's heart. It's not going to it's not magic, unfortunately, but it can be helpful in helping increase the rate once a patient actually has a heartbeat. Reversal agents are super duper important, right? So if you have a patient that arrests while you have them under sedation or anesthesia or what have you, make sure that you reverse anything that you absolutely can, because I mean, these drugs are just going to be working against you, especially something that has significant either cardiovascular or respiratory depression as a result of their drug that they've gotten, opioid, whatever it may be. Reverse them as soon as you possibly can, and that absolutely can help your the outcome of your code. Um, Another really important thing as far as giving drugs and IV access, make sure that you're following each injection with a large volume of flush. So certainly patient dependent, but usually it's going to be like a few milliliters to maybe 10 milliliters, depending on the patient size. If you're just giving the drug right at the port of the T-set and you're not flushing it, that drug is literally sitting there, or it's hanging out like in their cephalic vein for a minute while we sort of move the rest of the blood through the body for a while. So flush it, push it through that vessel, push it through to central circulation so it can disperse much, much, much faster. I don't want you guys to focus so much on doses. I mean, ultimately, those are going to be on their CPR drug sheets, which is amazing. It's also posted in that chart that I mentioned as well. But I want you to know why we're using each of these drugs and what they're actually doing for us. So helping with blood pressure is epinephrine's job. It's a positive inotrope, so it's going to help with contractility of the heart, and it's a positive chronotrope, so it's going to help with the heart rate as well. The big thing, you'll notice the orange at the bottom that has changed as far as the 2024 RECOVER guidelines go, is that we are no longer using high dose epinephrine. We have found that it doesn't correlate with a higher likelihood of return of spontaneous circulation. And it certainly can be harmful when we're treating cardiopulmonary arrest because of the increased demand on the heart, oxygen demand on the heart. And then ultimately that can predispose patients to arrhythmias. So again, no longer are we using high dose epinephrine per RECOVER in our codes. Vasopressin, this one isn't, it's a little, certainly helps us with our pressure, but in a different way. It works on your smooth muscle. It doesn't have any effect on the rate or the force of the heart, but it is something, like I said, that we can add in either with epinephrine or in place of, depending on how the code is going and what your doctor's preference is. Atropine is our anticholinergic that increases heart rate. Like I said, you have to have a heartbeat for atropine to do its job. This is most likely going to be helpful when you have a patient that has like pulseless electrical activity, which is PEA, or an arrest type episode because of high vagal tone. That's when atropine is going to be most helpful for you guys, but it is a staple still of CPR. Again, in orange at the bottom here, this big change is that we're not giving it like every other compression cycle as we previously had been. We're no longer giving it every 3 to 5 minutes. If we're giving it, which I recommend, it's worth a try for sure. I don't feel like it's harmful to give, but if we are giving it, we're giving it once early on in CPR and that's it. No repeated doses. So one time at the beginning of the code, and then from there on, we're only giving, our reversals or our vasopressors. A little chart of quick doses for you guys. It's based on 25 pounds. It's a nice little chart, obviously for quick thinking, but as we all know, when you're in an emergency, quick thinking doesn't work well, but can be certainly easier than doing hard math or long math in an emergency. 0.1 mLs per 25 pounds for epinephrine, 1 milliliter for atropine per 25 pounds. And then moving into vasopressin and defibrillation, I feel like we're going to refer to their ER drug sheets. So I want you guys to remember 0.1 per 25 for epi and 1 for atropine. I want you guys to know that intratracheal drug delivery is a great way to deliver drugs when we're having trouble getting IV access for these patients. If for whatever reason we can't, we're working on placing an IV catheter or we're having trouble doing it, or for whatever reason, we don't have IV access, you absolutely can give drugs through the endotracheal tube. What we'll do is use a red rubber sterilely, ideally, or as clean as possible. That's longer than the endotracheal tube, so we want the end of the red rubber to pass the end of the endotracheal tube within their airway. So we know that the drugs are actually being delivered to the airway and not the inside of the endotracheal tube. In this situation, though, we're giving doses of these drugs that are about, or I should say up to about 10 times what we would normally be giving intravenously. So keep that in mind as well. On our emergency drug sheets, the doses for intratracheal drug delivery are on there as well. But don't be alarmed if the volume that you're told to give to a patient is much, much larger when you're giving it intratracheally. For sure, these drugs should either be diluted in sterile saline or sterile water, or flushed afterward, right? So if you're just giving the drug into your red rubber and you haven't flushed anything, you could certainly have a decent amount of drug left in your red rubber, left inside the lumen of the endotracheal tube, or not dispersed as much as could be should we flush after we give the drug through the red rubber down the endotracheal tube. It seems contradictory to some extent to be putting fluid into the chest, and a lot of people ask about this, but we're using sterile fluid, so that's number one. We can deal with pneumonia later if we ever get to that point. But B, your patient is dead, right? So if we have no IV access, this is our next best option. ECG is really important, but the takeaway I want you guys to remember about this is that it's essentially useless unless we are pausing to check what the patient's rhythm is like. So if you're doing chest compressions for a patient, the rhythm that you see on the ECG is going to be the rhythm that you are creating for that patient. Unless obviously you've taken a pause, you've allowed the patient a chance to obviously display their own rhythm on the ECG should they have it. But this is really important. ECG is really important because it can tell us if these patients have a return of spontaneous circulation, but also if and when they have, do they have an appropriate rhythm? Do they have an arrhythmia? Is this a patient that should be defibrillated? Is the rate appropriate? Is this maybe a patient where atropine might be helpful? Other complex abnormalities that we can adjust, electrolytes, that sort of thing. The takeaway about ECG is that it has to be done super quickly and it has to be done in between pauses. Compressor pauses or doctor pauses. We're going to talk a little bit about defibrillation. We don't use it very often. From my understanding, I've been told that defibrillators are everywhere for people because the rate or the prevalence of fatal arrhythmias is far, far, far more common in humans than it is in our pets, dogs and cats. So you'll find defibrillators everywhere, public places that will do the work for you, basically. But in dogs and cats, we don't have arrest because of fatal arrhythmias necessarily, and ultimately using the defibrillator for these patients is not often indicated. The idea of defibrillation is that it delivers an electrical shock or an electrical impulse that basically reorganizes the myocardium or the cells of the heart, right? So there's only two shockable rhythms, and this is really important. We'll talk a little bit about this on the next slide as well. But I want you guys to remember that a defibrillation is not going to start a patient's heart. The only reason that we're going to be using this for our patients is if they're in ventricular fibrillation, which is basically like wiggles all over waves, I should say, quick waves all over the screen. Or if you have pulseless ventricular tachycardia, which basically means that your patient has a heartbeat, they are super tachycardic, so much so to the point where their heart is not perfusing to their heart is not perfusing to the rest of their body, and they don't have pulses as a result. So it's sort of like VTAC in the ICU, right? We have to treat that with lidocaine or some other antiarrhythmic. It's not a sustainable rhythm, so we have to defibrillate them to reorganize that. a nice little chart here. This was super helpful, and this is new as of the 2024 guidelines. If you are taking a pause to reassess your patient, check to see what the ECG says. The doctor is pausing to take a listen with the stethoscope. This is the time when we're going to assess the rhythm for the patient. So you can always check if they have a palpable pulse for sure. If you're at the back end of the dog or if someone else is listening with a stethoscope. And it's sort of like a nice go here, go there type thing, depending on the criteria that your patient has. So are there complexes on the ECG, regardless of what they look like? Are they consistent? Do they continue by the patient on their own, I should say? And if that's the case, then their patient may need defibrillation if their heart rate, or the rhythm rate, I should say, is greater than 200 beats per minute. And this is going to be the situation where we have pulseless ventricular tachycardia. So it's beating so quickly that it's not perfusing appropriately to the rest of the body. The opposite is true if you have a rhythm, a repeatable rhythm that's consistent, but is not a flat line, right? It is a rhythm, though it's very disorganized. These are going to be patients that ultimately will have a shockable rhythm known as ventricular fibrillation. So they just need reorganization of the electrical activity of their heart. There is a dose for it. It's about 2 to 4 joules per kilogram. This is also on their emergency drug sheet, so keep that in mind as well. The quick dose is about 40-ish joules per 25 pounds or so, if you ever have to know that immediately. But the tricky thing about defibrillation and why it's terrible is that if you guys have ever seen this, you are shaving the patient on each side of their chest while someone is still continuing chest compressions. So you're running into each other, you're shaving each other's hands, you're doing terrible things probably to their skin with the clippers. And you're applying a ton of gel to your paddles. It happens exactly like it would, or it does, I should say, on TV, right? So one person that's holding the defibrillator paddles is actually holding the patient in dorsal recumbency with one paddle on either side of their chest. And the person that's delivering the defibrillation has buttons on the paddles to deliver it whenever they're ready. You ultimately set the defibrillator to the appropriate dose. It allows itself to charge and be ready to give the shock. And just as you see on TV, like I said, you really do, and you really should say clear, or make sure that nobody's touching the table, nobody's touching the patient. Even the person that's delivering the defibrillation should make sure that they're only touching the paddles, not the patient, not the table, nothing else. Make sure that everyone is safe before you actually deliver this defibrillation. So that part, even though it might seem cheesy on TV, absolutely is true. If you do have to defibrillate a patient, you deliver your defibrillation, and then you immediately go back to basic life support for 1 cycle before you reevaluate. So don't deliver your defibrillation and then just sort of wait and see what happens. We've reorganize that electrical activity, but we still need to support the heart while it sort of gets going to some extent. We still need to support perfusion. So we immediately go to basic life support for 1 cycle, and then we reevaluate and repeat as necessary. I think this is our last change for 2024. The updates here is that if you do have a shockable rhythm and you've delivered a defibrillation to your patient that is not responding, you can double the energy dose, right? So the joules itself, and then use this higher or doubled dose for all your subsequent defibrillations, throughout the remainder of the code. In addition, they've also recommended that we immediately start antiarrhythmics, so lidocaine for dogs, and then amiodarone for cats, while we're trying to reorganize the electrical activity in the heart. Again, once we deliver our defibrillation, we immediately go back into basic life support for another cycle, and then we evaluate again. One big thing, I feel like this isn't such a big deal here, more so for when we present to referring veterinary hospitals. But for sure, if your patient has a reason that it might need corticosteroids, maybe it's had an Addisonian crisis, maybe you feel like it has this crazy profound allergic reaction or something. If you have a reason for your patient to need steroids in order to support them during the CPR effort, 1,000%, please give them. But the point is, don't just throw them into the mix because nothing else is working. We can definitely see a lot of side effects or adverse effects, especially for those patients that have poor perfusion. So other things to think about, not all patients that need CPR necessarily need fluids. If your patient is euvolemic, right, they have a normal blood volume or a normal circulating volume, they may not necessarily need fluids, though it is something that we often add in. Blood transfusion for sure. Are you basically working against the body's oxygen carrying capacity? Does the body not have the ability to carry enough oxygen? That sort of thing. In a situation like a blocked cat, is your potassium 10? Is that why your patient arrested? Correct that for sure, because that's going to help you or help you and your patient have a hopefully better outcome to your CPR efforts. Same thing with calcium, right? If your calcium's way, way low, that's very closely associated with your muscle contraction and your cellular communication. So correct your calcium, and that ultimately can help your CPR efforts as well. The last little part that I want to mention is that return of spontaneous circulation, like I said earlier, is never, ever, ever an endpoint. The best place to die, 1,000%, is under anesthesia, right? Because you're probably already intubated. You probably already have IV access. You have, a lot of the setup, if you will, already done and ready. For patients that arrest as a result of their disease, the likelihood that they're going to leave the hospital, unfortunately, even if we achieve return of spontaneous circulation, is really poor. I think it's like less than 6% for dogs and less than 20% for cats. And the risk for rearrest is so, so, so high, unfortunately. Again, for patients that arrest as a result of their disease. So these are the patients that we're able to achieve return of spontaneous circulation, but they have constant monitoring in the critical care or in the ICU. They have a dedicated nurse with them. It's super, unfortunately, expensive because of the care that they require. So when you're talking about CPR for patients with their owners, I always try to bring this up to them as well. Like, we can do CPR, that might be a few $100, but after that, it's going to be most likely be really expensive to maintain your patient or your pet rather, and support them to a point where they may potentially be able to leave the hospital. So just keep in mind that return of spontaneous circulation is never, ever, ever an endpoint. These patients always need some level of supportive care. Are there any questions that anybody has? Do you have any over on yours that I can't see?
No. Dr. Fidel just mentioned that if anaphylaxis, give epinephrine first. If steroid needs to give an anti-inflammatory dose. That's not a high dose. That's it.
Okay.
Do we stock red rubber catheters in the crash cart?
Yes.
Yes. Okay. This might be a silly question, but can you see these? Okay. When doing interposed abdominal compressions, are you targeting a specific area of the abdomen?
No. I mean, as much as you can, where a position where you feel you're going to get the best compression. So if you're too close up to like the rib cage, you're not going to be able to do much compression as if you could maybe at the center of the abdomen. Same as if you're really far back and close to the pelvis, you're not going to be able to do much compression there because of the the bone structure and the body structure. So I feel like the general soft squishy part of the abdomen is going to be the most helpful, wherever you feel like you can get the most squish.
What's our average cost of CPR?
That's a good question. So the CPR itself, I want to say is like 200, and then you give a handful of drugs. Yeah, like maybe 400 to 500 or so ish. And that's like basically you're getting going. If you have a patient that actually has return of spontaneous circulation, you're going to be spending tens of thousands probably afterward.
Yeah, for the ICU care.
Yeah.
Another question is, what's a good amount of flush to send down the ET tube after your emergency drugs?
It depends on your patient's size. Obviously, we don't want to fluid overload the lungs if you have a tiny, tiny patient, but enough to make sure that you have flushed the entire red rubber and you know that the drug has gone completely through it. So if it's like a super teeny tiny, like neonate, probably like less than 1 ml. But if it's a massive dog, we're probably going to be giving upwards of maybe 10 mLs or more.
Alexis says, thank you. Is it important when placing an ECG, should we be making sure we're using gel instead of alcohol?
1000%. I will say there should always be ECG gel ready to use for any type of situation. Like it should always be at the stations with the ECGs like attached to it. 1000%. But I don't think that if you're starting a code and alcohol has already been put on the patient, I don't think that's like a game changer. Like you continue as it is. It's just not the most ideal. Gel for 1000% should be better or would be better.
There's no more questions coming in. I have a simple question. I just need to know, if you did not put your last name in, please email me. Because I don't know who some of you are. Like there's just a Nicole, but we have several Nicoles that work here. So I just need to know who some of you guys are. I did private message you in the chat, but you didn't get back to me. I saw that Danielle Hirsch changed her from DH to Danielle, so thank you. But I just want to make sure that I give you guys credit. I think she mentioned this, but what percent is the success of CPR?
Return of spontaneous circulation for cats, if I remember correctly, is less than 20%. And then for dogs, I want to say is less than 6%, but that's just return of spontaneous circulation. That's not survival to the hospital. So even less than that, unfortunately. Again, like I said before, anesthesia or under anesthesia is the best place to die because everything is already good to go and you have the highest likelihood of return of spontaneous circulation given the circumstances. But again, when you're arresting as a result of your disease or what brought you to the hospital in the first place, your likelihood of survival to discharge, unfortunately, is really poor.
Yeah, I was always like, when people ask me, I'm like, your chances of returning are like this percent and this percent, but then your chances of leaving the hospital are like less than 5% of that percent.
Rearrest is very, very, very common, as we see, unfortunately, in the ICU.
Great. Well, thank you very much, Mallory. We appreciate that. And Danielle, are we closed on the questions? It looks like we're good.
Yeah, it looks like everybody's good with questions. If you have any other questions, obviously you can email Mallory with your direct questions. If you are watching this video on repeat, there is a quiz that's left in the notes section for you to click on the link to take the quiz. If you are watching this live, I have you recorded, hopefully. I have everybody that's in in the chat, and I have everybody that was signed in with your name. So I have everybody to record for live. You do not have to take the quiz, but if you're watching this on repeat, you do have to take the quiz and pass it. And that's in the notes section. There's a link.
Great. Well, thank you very much. Appreciate it. Thank you, Mallory.
Thanks,
Thank you,
guys.
Mallory. That was
Bye,
great.
everyone.
Bye.